Urgent, setting the scene. When a major storm surge makes landfall, it turns suburban streets into torrents of debris and structural collapse. Hours later, the physical chaos of that environment translates into a clinical reality. A patient arrives at an emergency triage center, presenting with a severe laceration or a fractured femur. Medical coders face a structural problem. They must document the macro-level epidemiological event, the hurricane, without violating the strict rules that govern the patient's primary clinical diagnosis. The designated tool for capturing this environmental context is ICD-10-CM Guideline B.19.a, the external cause of morbidity codes. Precise, analytical. To use these codes correctly, you must understand the concept of syntactic dependency. External cause codes possess zero clinical autonomy. They function as supplemental metadata. They provide a secondary layer of information to the patient's primary electronic health record, explaining the circumstances surrounding the trauma. To maintain data integrity, an external cause code must structurally attach to a foundational clinical code. It cannot stand alone on a medical claim. Treating an external cause code as a standalone diagnosis corrupts the individual medical claim and distorts the broader epidemiological tracking systems relying on that data. Before an external cause code can even be initiated, a strict prerequisite must be met. The patient must present with a verifiable physical consequence. The guidelines restrict this foundation to 3 specific conditions: a physical injury, an adverse effect, or a poisoning. If a patient presents with a general medical condition, like a routine asthma exacerbation lacking physical trauma, an external cause code cannot be assigned. Attaching an external cause to a general condition creates a logic failure. The system rejects the entry until it finds a physical trauma to anchor against. Metadata about location or cause has no structural utility. It requires physical trauma to give context meaning. Coders operate as the gatekeepers of this logic. If the foundational physical injury is missing, the external cause code is systematically invalid. Once that physical prerequisite is established, the external cause code activates, layering specific contextual data into the record. The first 2 layers detail the mechanical cause of the injury, such as being struck by falling debris, and the intent behind it, identifying whether the event was accidental or intentional. The third layer pinpoints the geographical or structural location where the event occurred, like a flooded residential street or a collapsed roof. The final 2 layers document what the patient was doing during the event and their demographic status, differentiating between a civilian resident and active military personnel. These 5 distinct data points converge around the primary injury, forming a standardized epidemiological profile for a single patient encounter. This structured metadata is the mechanism turning a physical laceration into a trackable public health statistic. Guideline B.19.a codes do not alter the diagnosis of what the injury is. They provide the legal architecture defining how, where, and why it happened. Defining the context is only half the process. Coders must also navigate the sequencing rules that dictate the literal order of codes on a medical claim. The unbreakable directive is clear. The clinical manifestation, the injury code, must occupy the first listed position. Following that, the external cause code must be sequenced in the second position or lower. This equation illustrates the AMCI MJ-GEM mnemonic: injury first, cause second. It is a fixed formula governing the claim. The operational maxim driving this law is that the cause supports, it never leads. Coders must actively suppress the instinct to prioritize a massive event, like a hurricane, over a mundane physical fracture. Violating this sequencing law misrepresents the immediate clinical reason for medical care and leads to the rejection of the claim. These rules extend across the patient's entire continuum of care. A disaster victim typically moves from emergency triage to an inpatient hospital bed and eventually to an outpatient follow-up clinic. Guideline B.19.a establishes a continuity rule for this journey. External cause codes must be assigned at each individual encounter where the injury is actively treated. A common error occurs when coders drop the external cause data during follow-up visits. The context must remain attached for the duration of treatment. This continuity mandate applies universally, regardless of the healthcare setting or the location where the care is provided. Unbroken assignment of these codes is the only methodology that allows public health agencies to track the long-term healthcare burden of a disaster. On a national level, these individual records aggregate to provide a clear view of disaster impact. Thousands of sequenced injury-first claims flow from local clinics into centralized tracking systems. This syntactic adherence creates the statistical backbone necessary for coordinating large-scale disaster response and tracking injuries across a population. Coding errors lead to incomplete patient narratives and incorrect reporting. This results in the loss of valuable data used by public health officials to monitor natural disasters. Coders must maintain a rigorous internal checklist, verify the physical injury prerequisite, determine the contextual cause, and enforce the sequencing law. Capturing the full epidemiological story depends entirely on treating the external cause as a supporting element to the clinical diagnosis. Through the application of syntactic dependency, medical coders provide the structural accuracy required for national public health analysis.